Next, we are going to invite Dr. Akila Andiapan, the Deputy Director of Health Screening and Management at Health Promotion Bureau in Ministry of Health in Singapore. Please come up to the stage. Okay, Dr. Andiapan will talk about the next chapter of Singapore National Screening Program. Let's welcome Dr. Andiapan.
Good morning, everyone. Thanks for being here. Quite difficult to follow. Yes, we have a lot of our friends from Singapore. It was nice to see them on the pictures as well. I'm not taking this futuristic view because I'm coming from the government perspective, so it will be a little bit more measured in what we think the colorectal cancer screening landscape looks for in Singapore as we move forward. That is Singapore, about half a century back. My topic today will be on what the evolving landscape is going to be, and that's Singapore just last year. And we just completed our 60th National Day anniversary, which is just a couple of weeks back, celebrated our 60 years of independence. So there's a long way to go for us, even though we're a small nation. So I will just cover very briefly what is the major initiative under the Ministry of Health and the Government of Singapore for the healthcare side, and from there how it will then sink into the Screen for Life, and what we think will be some of the future aspects where it can come from. It is actually a multi-stakeholder kind of involvement, but I'll probably be giving more of the government. A very quick recap to what we discussed yesterday. We talked about, despite the fact that we have a major national screening program, which is pretty well established, we do have multiple challenges across the entire end-to-end service journey. And very simplistically, I was sharing about the 3 Ps: the population factors, the provider factors, and the policy factors, where we have challenges with screening uptake despite sufficient knowledge or awareness. We do have issues with post-screening compliance, where we had a lot of issues with follow-up, and provider factors equivalent to that with the surge in the post-screening workload. Our supply side hasn't met up that much, which has increased the wait times for referrals at most of our hospitals now. And from the policy perspective, there are gaps which we can definitely fill with cost in terms of the affordability, gaps in terms of the screening journey, as well as IT infrastructure. But when I say IT infrastructure, it's about the repository for screening and looking at the client from an end-to-end screening journey. And we did look at what are the levers in particular we need to look at as we move forward. And for this piece, very simplistically, where Health Promotion Board and Ministry will be looking at is key part for, at least for HPB, would be how to change the behavior of people to come forward to screening, as well as how we narrow the gap for screening follow-up. And then what are the tools and platforms where we'll be looking at bridging all of these gaps, and what are the policy levers, funding levers, operational models, and so on. That's a very quick recap. So before I go to the full section of where we are heading, similar to most Asian countries, Singapore is also becoming an aging nation. Close to 1 in 4 or 1 is to 4.5 is actually an elderly person in Singapore, and our rate of aging is pretty high. Despite the fact that we are a small nation with only about 5.5 million population, it's still, from a proportion point of view, it's quite high. That's and similar to what most of our Asian counterparts shared yesterday. We also have the same issue as far as the chronic diseases and obesity prevalence is concerned. We have this dual burden happening in Singapore. And when we match it against what the system level goals are for Singapore, of course, we are always striving to improve the quality of care, and of course, managing it against how do we actually reduce the healthcare burden. And I think the key would then be how do we balance all of these for optimal health outcomes. And I think, as coming from the government perspective, that's the major challenge which we've been trying to address, and it's still going to be a major challenge as we move forward. So I shared yesterday very briefly about the Healthier SG, but the program, which is the national program called Screen for Life, has now evolved in a newer landscape. under the Healthy SG. A very quick brief about what the Healthy SG screening is about. SG here stands for Singapore, by the way, but it just in case. So it's a major national initiative which we just started a couple of years back by the Ministry of Health. And it is aimed mainly at looking at preventive health, where we want to actually empower citizens to manage their health proactively, not from a reactive angle. So it was heartening to see that most of the speakers yesterday were also alluding to the same fact. How do we move from treatment to prevention? How do we move from from reactive to proactive? And from the tertiary all the way, how do we push everything upstream to primary? That is also the key area, and this is a major transformation area as far as Health Ministry and HPD is concerned. So in this strategy, we look at 3 key pillars. The first and major pillar would be anchoring care around the primary care provider, the GPs in particular. So the key area would be each Singaporean, as we call our local residents, each Singaporean will be attached to one primary care provider. So one family physician, one Singaporean, that's kind of our goal. And each of them will get one personal health plan. In this health plan, it doesn't actually look only at screenings. We have 6 key areas of domains which we call. It covers screening, vaccinations, physical activity, diet, mental health, as well as smoking, or rather anti-smoking and vaping. So each resident who goes through a GP clinic or a polyclinic, whether it's private or public, will go through the personal health plan, depending on their personal history, their family history, as well as their risk profile. They get an annual health plan, and then based on the health plan, the next key area which we've done is improve the access to all other services. In the past, there was a lot of services which were offered desperately all over the place in a way. There were connections, but I think from a client view or a consumer view or a resident's view, these were all not integrated. What we've now started looking at is within the community. So we bring health to the residents within the community. That is something which is critical here. And all of these services are now linked back in, such that we are working towards how we move this entire journey for the client in more seamless way. And of course, there's a lot of back end with IT infrastructure, funding levers, policy levers, and so on. A lot of dirty work going on behind the back, and a lot of strenuous investment. So with this, a key shift in this is not just looking at health from a health angle. I think Dr. O also mentioned yesterday about health and all policies. We've also had that always, it's just that it was not so predominant. And now our minister actually has managed to push this agenda through, and we are now looking at a social health inclusion. So in health plan, we have a key item which is called the social prescription. So beyond having a health prescription, which is my medical prescription, what do I need to do from a social angle? How do I then improve my health? So what are the exercises or physical activity I need to do? Where do I go? Even all the way up to mental health. That would be an indirect component of this. Which is why we have moved away from, these are the 3 clusters, healthcare clusters we call them. So in Singapore, we've organized them very simplistically, East, West, and Central clusters. So each cluster will then take care of the residents in their region. So these are actually, they usually will have an anchor hospital, and they look at population health for the individual. And these clusters will then work with the ministry as well as HPD and other entities within their community to bring health to the residents. And the health, again, we're talking about the entire spectrum, right from primary, preventive, to secondary, tertiary, and quaternary care, all the way up. And if need be, they will also be sent back and discharged within and into the community. So that's the whole idea. So we bring in a lot of community partners, including even aging, because I think I shared earlier, you have a major challenge with aging. So this huge shift in the ministry's policy, the health system, has also changed and brought in a lot of opportunities for us, which we probably didn't have as much leverage in the past. So one key area which we had is how we have integrated the primary care providers and community providers to offer screening. The second has been access to underserved populations like more of a Malay population, as I said, ethnic minority community, as well as lower income group, and also to bring in that community level engagement, both at citizen level as well as with the community level. So moving with this, the first major change which has happened is the national program called Screen for Life has morphed, evolved, and now tucked under the Healthy HG initiative. We are now called the Healthy HG screening to give it the national front and a bit better understanding with our consumers. And we have three major policy shifts. The first one is all the screenings are now offered free for those who are enrolled to our program. The second would be, irrespective of whether they are in the private or the polyclinic, the public sector, again, there's no gradient. They will get the similar kind of services, they'll get the similar kind of quality, and there's a standardization of care and prevention and health plan across both sides. The third is, and the most key, which is kind of something very specific and very integral to screening, is the fact that all the primary healthcare providers, who are the GPs and the polyclinic, whether the polyclinics or at the private center, they will be responsible for their patients' health plan and health, which means we are moving from a more opportunistic screening in the past. Even though with an organized national screening program, we are now moving into a clearly structured, organized program where the GPs and the doctors will now take charge of the client's health. But in Singapore, we've had this principle about what we call an ownership, co-ownership of health. So the government cannot do anything and everything for the residents. So we always ask for co-ownership. Now we have actually brought in our PCPs as a key tenet to this principle. So it's between the government, which is the program, the residents, and the GPs. There's a very close-knit relationship, and this we hope will actually move the needle. So very quick about the stakeholders. Yesterday I shared about basically what the stakeholders look like, but moving forward, as you can see, the clusters, who are the healthcare partners, the community partners, as well as the GPs or the PCPs, the primary care providers, they're going to be taking a much larger stage. HPB, Ministry of Health, we are still there, but we're going to be moving backstage and giving most of the care forward to the healthcare folks who are more in the, what we call the frontline staff, who are more in connection with the clients as well as with them. So the second one, how has, I just thought it's easier to give a case example. I don't have time to go through all of it, but just a very brief about how HPB has adapted to this Healthy HG. We moved on to upping ourselves as a Center for Operational Excellence. We do, because of the very many different stakeholders who are involved, we do have a bigger push on partnership and collaboration, as well as with all of these, again, we have the same issue with standards and quality assurance. But a very quick one is to talk about customer centricity, which is kind of the pillar for all the Healthy screening. One of the things we've done is a person-centric design using behavioral insight. This is something which is critical to us. For example, you can look at a pilot which we did is using BI, which is behavioral insights, technology, insights principles here. So this invite that was initially sent, we did a pilot where a trial against the control. We did two arms. One treatment arm, which the blue one is the one where we told them about go get screened before a particular date. The control arm 2 was on social norms, where we told them, okay, 90% of Singaporeans go for screening, or 80% go for screening, why not you? And interestingly, you can see against the control, which is the black line, both control arms, both intervention arms did perform better. But interestingly, the blue line, which talked about the time stamp, actually had not just the first search, but the second search before the deadline to say, everyone's sampling came up, because they just realized that in Singaporeans we have this loss aversion, so they don't want to lose out. So suddenly they just realized, oh, it's 30 September, let me go for screening. I don't want to lose out because it's a free screening. So these are some of the areas which we think we can start applying in our consumer messaging. So what we've done is, we have two national front doors, that's what we call. One is the Health under the Ministry of Health, and we also have the HPB, we also have something called the Healthy 365, two major apps which we use for all our health information, results, etc. And this app has been upgraded such that clients can get more seamless information about their appointments, about their results, and medication list, etc. And what we've done now is we started building our screening journey, which is a digital journey, onto these two apps, in particular the Health Hub. And there's a very quick sample of what happens. So for example, if I am female of a certain age. It will tell me what are the type of screenings I need to go for, and if I've already done. This will also link me to say, okay, ready to book. Please go and get it, and we'll give the link to the health appointment system, and from there it will tell them, okay, this is the appointment, and closer to the appointment date or twice before, they get reminders to say when to go and your appointments are coming, and they'll also give some key information to say, do you need a fast, how do you prepare yourself for the screening appointment, and so on. With this, just a very quick snapshot about how our program has performed since the launch. This is actually what we normally do for our analysis is we look at a seasonal trend across the years. So this is the baseline, which is the dotted line. And the red line is when we started the screening program somewhere in July, the health age screening, and the blue is after that. So you can see that it's a huge jump in the numbers, participation numbers actually went up at least double for us within the program. But yeah, with this, it was not always good news with what I shared. Another problem we had was about the post-screening workflow, which went to the hospital. We had close to 3 to 4 times the higher workload which the hospitals couldn't manage. So the different colors are the different hospitals which are participating, and you can see across the year, all the hospitals had an increase in their workload, and the wait times correspondingly also increased for participants. So this is a challenge we have, and that's something we need to look at as we move forward. So what does the future look like for Singapore? We have done quite well as far as the cost concerns are concerned in the healthy energy space, but I'm sure we can do more for the lower income group to get how to make it more affordable. Gaps in the client journey have been addressed to a certain extent, but similar to the previous issue on cost, IT is something major for Singapore, and there are very many different IT systems. A lot of integration needs to be done. I think anyone who's there with the IT infrastructure and digital space will know how difficult it is to get the networks going. And a lot of these systems are actually what we call as older systems, legacy systems. So to evolve them and integrate them is going to be a huge challenge. We started work, but we have a long way to go before we can go somewhere there. And the second part, which I shared earlier about the stakeholders and getting the buy-in, because we didn't have sufficient time to engage the stakeholders to up their supply, we were in a slightly an issue. But now we're going to be working with all the cluster partners to say, okay, now we hand over the baton to you. How do you then going to manage all the workload? So the cluster partners are now looking at how to do their supply side. On population factors, of course, as what I shared, we are going to be doing a lot of work on our messaging. How are we going to be looking at customized personal messaging, working on the digital front door, looking at thematic campaigns to address a lot of the myths and misconceptions which we have. And of course, the most important will be the helpline consulting, where our GP partners and polyclinic partners will also be partnering us to be sharing this similar kind of messaging with our population. And I think some of them are asking about what do we do for the ethnic minorities and the lower income. We do have, besides the GenPop approach we have here, we do have targeted intervention. A small example is called Jom Check. Jom Check in Malay actually means let's check, let's get screened. So this is something where we bring in the local community, people from the Malay community. They are the ones who actually are the voice, and then they come up there. I'll just wrap up with the last one to say where do you think the next chapter of colorectal cancer screening can be is, I think our previous speakers spoke about the very advanced level. We're not there yet for the government level, but at least what we are looking at is what are the normal screening tests, possibly some of these. We've already started looking at teleconsult and video consults for some of our post-screening follow-up. We're looking at AI-assisted colonoscopy. We've also started looking at risk-stratified screening, so we are happy and we'll be ready to learn from Taiwan. I think we're pretty much there. We've just rolled out the genetic testing as well for the familial adenomatous polyposis, the FAP-rich syndrome. Interestingly, yesterday, speaker was talking about leveraging 7-Eleven for pickup and return. We're also looking at something like that, kiosk, which we used to dish out masks during the COVID. Those kiosks are now actually not being used. So we thought we probably use that for tickets, pickup rate. And of course, last but not least, is something we are also interested in. And thank you for a very good opportunity. And that's
Thank you. Thank you.